It's recording, yeah.
Recording, okay. So you're going to have to sit down. Can you record? Right then, Viral.
Hi, Dr Wijaya.
So we're going to be looking at a case-based discussion today.
Okay.
Okay, so what case have you decided to bring?
Yeah, there was this case of a 31-year-old who had what I basically thought were simple UTI symptoms.
Yeah.
But the case got a bit more complicated by the investigations I chose, and I just want to discuss whether or not they're appropriate, and in future cases whether or not we would do the same sort of tests.
Okay, so tell me about the case.
So basically what happened, it was a 31-year-old lady who's generally quite fit and well.
Yeah.
And she came in because for the last week she noticed increased urinary frequency, so passing urine maybe hourly while she was awake. She also needed to go at night time pass urine about once. Now, she's always said she'd had a bit of frequency to some extent, but this was a lot more for her compared to normal. There was no dysuria, no fevers, no incontinence, no urgency, and no loin pain, anything like that.
Right.
There's no bowel bladder symptoms,
Yep.
neurological symptoms in the legs at all. So, I was thinking, this sounds like a very typical UTI case.
Yeah.
Let's do a urine dipstick, and if that's positive, treat it. Of course, what then happened was the urine dipstick was negative for leukocytes and nitrites, and the urine looked completely clear.
Right.
So it kind of left me in a bit of a no man's land, because I was a bit confused now. Does that mean I treat this or not? And if I were to treat it, well, would I send an MSU or not? Because I see I've dug myself a bit of a hole here.
Yeah.
So
what did you end up doing?
What I ended up doing, so in this case, I decided well, in this case, because the urine dip was negative, at that time I thought that's a pretty good rule out. And so at that time I said, look, I'm not going to give antibiotics just yet. I'll send an MSU, and if that's positive, I'll give you a call and I'll give you some antibiotics. If not, we'll just see how it goes. If it's still persisting after, say, a couple of weeks, come back.
Right.
We'll go from there. In the meanwhile, I read up a little bit about this scenario.
Where did you do your reading?
I did it a few places. So the BMJ, there was an article actually about investigating, about urine dipsticks in when to use them. The RCGP has also written a guideline I had no idea about, telling you exactly when to use a urine dipstick in primary care. And so I kind of looked at those, and I found out some fascinating things. So I'll just bring up.
Yeah, let's have a look at your case as well.
Yeah, okay.
The case now. So what did you document on the day? Let's have a look.
Okay, so I wrote down 1 week of increased urinary frequency, more than hourly.
Yeah.
1 episode of nocturia per night last week.
Yeah.
Always had frequency to some extent, but feels more than normal, and this is affecting activities of living like shopping, driving, etc.
Right.
No dysuria, no incontinence, no urgency, no back pain. Sometimes feels the need to pass twice in succession.
So at that point, did you have a provisional diagnosis in mind?
I mean, yeah, at this point I would be thinking UTI.
UTI. Yeah.
And there was no leg pain, weakness, numbness, no bowel bladder symptoms, no back pain. Didn't seem like anything more serious behind that.
Okay, so have you documented all of that?
Yeah, that's there. And then on examination, she was soft, non-tender, no loin pain. Her temperature was fine, 36.7, her pulse was 90. And her urine dipstick was negative and also looked completely clear.
So you documented there, your abdominal examination was soft, non-tender, no loin pain, she was afebrile, and pulse was 90 beats per minute.
Yeah.
What about blood pressure, respiratory rate? Or you didn't normally...
I wouldn't do it routinely because she looked completely well, and I wouldn't have...
Right.
I wouldn't have, with a normal... She wasn't really complaining of anything like it. Just seemed like a normal kind of lower urinary tract symptoms.
Okay.
So
you took your MSU.
Yeah.
Yeah. And then obviously your MSU, what have you documented there?
So we'll send for MSU as has frequency causing significant social impairment, but no other symptoms and completely clean urine. So I documented I was a bit kind of unsure exactly what was going on. I told her if it's carrying on for 10-14 days, then we might have to considering maybe overactive bladder or a different diagnosis if it's a negative MSU and she's still having persistent symptoms. Right. So the urine dip actually did come back as clear for everything.
You mean you said
the MSU's come back as clear for everything. Pus nil, red cells nil, no significant growth. So it kind of supports, retrospectively, not to give her antibiotics. But in future, I was wondering, right, if this patient came in again with the exact same presentation, when should I do urine dip, and how much should I be influenced by a negative urine dip if I strongly believe there are symptoms? What I found was this. I wrote it up. What I ended up finding was some guidelines, which I'm just going to bring up, which were incredible. So basically, they said if you've got 3 or more.
So where are the guidelines from? The
this
HPA?
is from the HPA. It's also endorsed by the RCGP.
Yeah.
And also the British Infection Association.
Right.
And it's specifically for UTI in primary care.
Yeah.
So basically, it reframed my differentials. It said, right, yes, UTI is pro-top, but maybe I didn't think back at the time, but looking back, I probably should have thought more about, could it be like a urethritis or maybe a gum cause as well?
Yeah.
Now I'm more aware of that. At that time, I don't think that really figured high on my list, and I didn't really take history for the gum causes particularly. But it says over here, if you've got dysuria, frequency, suprapubic tenderness, urgency, polyuria, hematuria, if you've got 3 of those, or they're very severe symptoms, then you don't even need to do urine dipstick. It says 90% of the time it's going to be culture positive. Right. Anyway, you can just start empirical treatment. Yeah. So I guess in this case, that might have been the way to go initially, you could have argued. But if you think about it, it came back negative, so it kind of, do you see what I mean? It left me a bit, if you follow that letter, that would have started treatment. The next option is if you have mild or less than 2 or less symptoms, you take a urine sample, and this I found very interesting. Apparently, if it's cloudy, if it's not cloudy, the negative predictive value was 97%. Then I found out that the negative predictive value of a urine dip, negative for nitrates, leukocytes, and hematuria, was only kind of in the low 90s.
Right.
So if you compare the two, it was actually a better test to have a not cloudy urine dip as a rule out compared to a clean negative.
So what was her urine dip?
Her urine dip was clean for.
Have you documented that?
Yeah, I have. Yeah, I've written. It was clean for nitrites, leukocytes, and completely clear looking.
Right.
So yeah, I mean, I'm just wondering about the whole point of even doing a urine dipstick. Having seen it was clear, you could argue that that's almost according to those guidelines, is actually good enough rather than doing the actual dipstick. Yeah. It's got a better. If you're using it as a rule out, it's better than the dipstick itself. So that was interesting. And then if it was positive, it had a strategy. So if you've got positive leukocytes and nitrites, or positive nitrites, then just treat, basically nitrites you're going to treat as a UTI. If leukocytes positive and nitrites negative, its approach was you weigh up. If UTI is your topmost diagnosis, then you probably would treat it. But if there's something else, you'd really consider that something else more strongly. And if they're negative, then you'd really, both of them, you'd generally consider other diagnoses.
Right. So it's interesting. So you've learned that today.
Yeah.
Today about doing the obviously.
Looking at the colour of looking at actual urine as a better rule out than the urine dipstick itself, which I found very interesting.
Okay.
And also, when you've got a good going history, you don't actually need to do a urine dipstick. Right. And it's really strong.
So looking back at the case, so you bring up the notes of the case again.
Yeah.
How did you leave this with the lady? How did you leave this with the patient?
I told her basically if it's, I'll send off a sample. If it's growing anything, I'll let you know. Give some antibiotics. If you don't hear anything and the symptoms are still there, say in 10 to 14 days, something like that, come back.
So was that your safety netting, or did you do any more safety netting?
That wasn't my safety netting. I mean, I guess you should probably consider if you get fever, loin pain, difficulty passing urine, if you're feeling generally unwell, or you see gross hematuria, probably would be one as well. Actually,
right. Then what would you advise her to do then?
So if she was to depends on the depth of the symptoms. I mean, if she's feeling generally well in herself, maybe if she's had some loin pain and is otherwise well, we could probably see her initially. But if she's getting anything more than loin pain plus fever and other issues, then probably seek something more acute.
Right.
Probably any if it's feeling unwell and septic with it.
So how do you document the screening? So you documented if persists more than 10 to 14 days, we'll consider urodynamic stroke overactive bladder.
Yeah, or the incontinence frequency is causing distress. So that was the
right. So perhaps in the future cases when you've got a case like that, maybe an idea just to put any other safety netting advice related to the lady's consultation, so that obviously she does develop rigors, loin pain, vomiting, that she should seek medical advice. So safety netting is a very important point. That it's very important to document there. Okay. So the other thing was I wanted to ask, what about your your differential? So you've got a negative urine.
Yeah. So the other causes, so you could have something not related to the UTI itself, so it could be a urethritis or a gum type cause.
Right.
Or it could be or vaginitis, cervicitis, all whole host of things it could be. Then it could be, if you have UTI-like symptoms and negative cultures, then the other couple of things you think of are, particularly in her case, overactive bladder, because she's having frequency more than any of the other symptoms.
Okay.
And I guess, one that clues that hope it would usually persist a bit more, wouldn't be in such an acute presentation usually, although not always.
So if she came back to you, this 10 to 14 days, she's still got problems, she comes back and sees you in a couple of weeks with a negative urine dip, what are you going to do then?
I think I'd now consider the other diagnosis like interstitial cystitis and overactive bladder.
So how would you progress?
So going back to history, I mean, it's very difficult on history alone to distinguish interstitial cystitis from UTIs. They present very similarly. I think one of the features is they feel, as the bladder is more full, they start to feel more symptoms at that point, so maybe you could try and tease that out. If it's an overactive bladder, I think if you're suspecting that, you look for risk factors, so any other neurological symptoms at all, though most of them won't have something else, but it could be secondary. And if that's the thing, then usually I think urology to really investigate that further, because you can't do more tests from here. You could try, it depends how the patient feels and how confident you are with the diagnosis.
So if you're confident
diagnosis, then you could start empirically treating from here.
So how do you treat overactive bladder?
You just sort of want something to relax the bladder muscle wall, so something like oxybutynin or something like that.
Would you advise any lifestyle advice for
so you look at her fluid intake. In fact, it might be useful to get a avoiding diary in these if there's doubt, and help you work out how much is she avoiding each time. Is she having high frequency volumes? Is it low? What's going on? You could check her caffeine intake. You could check when she's taking her fluid compared to her bedtime. Is she taking the right times? I'm sure she probably would be. And beyond that, obviously alcohol sometimes can cause problems. So check the intake there. Beyond that, I suppose you could argue she could probably check a pregnancy test actually, if she's having frequency and no other cause.
That's important, isn't it?
Yeah. So there's that, and
so you could advise lifestyle advice, possible trial of something initially if you're confident there was an overactive bladder or irritable bladder.
Yeah.
Okay. You mentioned interstitial cystitis. What would you do to investigate that if you need to?
That one's a tricky one, because I'm not sure what the specific investigation is. As I understand, it's not quite a diagnosis of exclusion, but it's suggested strongly by UTI symptoms in the presence of negative culture. I'm not sure exactly what the investigation is to definitively confirm that. I don't know if urology would do that, or would we...
Would you consider referring to urology have you had that diagnosis in mind?
I mean, in itself, my understanding is it's not in itself particularly dangerous in itself.
Right.
So, I mean, if you've got doubt with the diagnosis, I think you can't just hang on to a patient if you don't know what's going on.
So you'd
probably have to, if you consider something, you don't know how to confirm it.
Okay. So how's this case, I mean we've touched on it briefly, how's this case change your management for future cases?
I think
are you going to be urine dipping people, or are you going to be looking at them for cloudy urine?
I think a few things. Number one, I'm not going to, before this I was kind of going, right, you've got UTI symptoms, I will bow down to the urine dip and follow whatever it says as my guide whether or not to treat as a UTI. And I know there's a bit of a pretest probability for take into account. If the pretest probability is so high, they've got classic symptoms and signs, then your urine dip, if it's negative, is more likely to be a misleading false negative than in an unselected group. So it's probably adding more mud to the water than actually...
So if they've got more symptoms...
If they've got really good symptoms, then it's probably going to confuse things if it ends up being negative.
Yeah.
So I won't always do a urine dip necessarily.
Yeah.
In terms of, if I'm doing a urine dip, I will make sure I actually document what the colour of the urine looks like, more cloudy or clear, because that will actually help. If you're looking back, it gives you a much stronger negative predictive value of that compared to the actual urine dip. So I'll look at that more. And I think I'm going to think a little bit more about the kind of the obs and gynae causes of similar UTI-like symptoms, in particular vaginitis, cervicitis, and pregnancy itself.
Okay.
So I think I'll have a think about those, and then if it persists, I've got to make sure I'm documenting all the safety netting features, in particular, evidence of pyelonephritis. And then I think strategy for when it persists. So I think if I'm confident with the diagnosis, sounding like an overactive bladder, I could just start empirically treating.
Yeah.
If I'm not, I might refer for urodynamics or something like that to check.
Right.
And interstitial cystitis, we'll probably have to read up a bit more about exactly the investigations.
So I think that's something to go away and have a look at today, isn't it? It's
Yeah.
interstitial cystitis.
Yeah.
Pardon me, my voice is going.
Yeah.
Good. Okay, well let's get this marked then, shall we?
Yeah, cool, let's do that.
Excellent.
Yeah. Oh man. Is yours record? Can you test it? No, this hasn't. This is an old computer. In fact, when I go home, next time I come, I'm going to bring a little adapter, and I'll sort out your phone. And what you can do from that point on is you can directly record from here, and put it straight on your phone, and you can start doing stuff with that. Don't tell me you didn't record.